This webinar on aortic valve disease. My name is Dr. Oliver Strom. I'm one of the staff cardiologists at Stevenson Cardiovascular MRI Center. Aortic valve diseases consist of two different entities. The one is stenosis of the aortic valve, which means a reduction of the systolic opening area, which may be due to degeneration, infection, and/or aging. And the other part is regurgitation, which means there's a backward flow of blood in diastole into the left ventricle, most often due to degeneration, infection, and again aging. The problem with aortic valve diseases is that they are often asymptomatic for a long time, and that in some patients quantification with ultrasound is sometimes difficult due to patient factors or just technical reasons. The clinical presentation of any aortic valve disease most often comes with shortness of breath with exertion, with a limited exercise capacity, and sometimes patients present with arrhythmias or after syncopal spells. At the end stage of the diseases, most patients present in heart failure. What are the imaging targets for the CMR study? Like always, cardiac function is one of the main parts of the CMR study, which is assessed with multiple long-axis SSFP cines, or in short axis stacks. Then we need a high-resolution cine of the aortic valve for our planimetry. And most important, we need phase-sensitive or flow sequences for the assessment of blood flow over time, which means we get the forward and the backward cardiac output, and we can calculate the regurgitant fraction for the valve. The anatomy of the aortic valve has to be described bicuspid versus tricuspid. The orifice area in aortic stenosis needs to be quantified. And of course, in aortic regurgitation, the regurgitant volume and the regurgitant fraction are our main imaging targets. The clinical case for today is a 68-year-old patient who presented with increasing shortness of breath and unfortunately had a technically very limited transthoracic echocardiogram examination. So we were asked for the CMR as a second opinion for the quantification of his aortic valve regurgitation. So this is the patient. We prepared some of the contours already just for the sake of time. Like always, we double click on the patient name to load the study, and then are presented with the study overview. You can see the localizer images here. You can see one of the examples of our multiple long axis stack, short axis localizers, and then the specific localizers for the planning of the flow measurement in the ascending aorta. We already see the regurgitant jet here in the aortic valve. We have a second localizer in a second long axis orientation, now perfectly giving us the perpendicular view of the aortic valve here. We have the high resolution cine here of the aortic valve. And then you note that we have 4 different flow studies. The difference between those is the so-called VENC, or velocity encoding range, which means the speed for which the sequence is optimized. In this case, it's 150 centimeters or 1.5 meter per second. In this study, it's 100 centimeters per second, and you see some typical aliasing in the systole, so this VENC is a little bit too low. And then just to double check that the 150 is not too high, this is a VENC of 125 centimeters, and you clearly see there's still aliasing, so we will need the 150 for our flow evaluation. As I said before, we already drew the contours, so this is just the example evaluation of the multiple long axis. Again, you can load in a different short axis localizer here, and you can display the cines while you see the corresponding orientation on the short axis here. This patient presents with a normal cardiac volume. The end-diastolic volume is 185 milliliters. His stroke volume is high, but its ejection fraction is only 50.1%. The mass is normal, so this looks like a mildly reduced ejection fraction in a patient with aortic regurgitation. We can see the aortic regurgitation, but as we know, the SSFP and other cine images are not very reliable in the quantification of the degree of regurgitant or of regurgitation, and for sure do not give us any explanation or any good reading on the regurgitant fraction. To solve this problem, we take the flow images and we load them into the flow module. just by dragging and drawing them into the flow module. You see the two different parts of the sequence. You see the flow information on the left side and the anatomic information on the right side. You can select one of the regions of interest, 1, 2, 3. The fourth gives the possibility to have a flow maximum. To draw the contour, there are two possibilities. You can either draw them all manually, like this, or you can select the contour and click on the contour detection tool to see the contour grow to the expected and maximum aortic diameter. And by clicking the forward contours to all slices, you automatically get a very fast and in most cases very precise delineation of the anatomy of the vessel under investigation. We of course have to make sure that all the contours have been drawn in a very good and very reliable fashion. So I would just correct this here a little bit on the lower side and maybe here a little bit. As you can see, in most cases there are only minute changes needed after the computer draw the contours. The readout already gives us a forward and a backward volume. The software of course does not know in which direction we are heading, so you have to look at the curve. In this case we have a negative coding for the outward flow, so the backward volume here would be our forward volume of 86.4 mils and a backward volume of 25. We know that there may be a problem with the background correction in some orientations in some patients, depending on the manufacturer and the sequence used. To account for this, we use the backflow or background correction contour, which should be approximately the same size as the ascending aorta or the vessel we are investigating. We can forward this contour by pressing Command F to all the slices without contour detection, because we just copy it. And now we can see that this part of the patient did not move, so we can use this for background correction. We can display the flow in the background correction contour just by clicking on the Roy selection BC, and as you can see in the readout, this is a very technically acceptable study with a backward flow of 0.7 and minus 0.3 milliliters. By applying the correction to the background correction, we change our flow analysis only mildly, but this is just more precise, so it should be done in all patients. We now can easily calculate the regurgitant, or we can assess the regurgitant fraction by just looking at the calculation of the computer. It's 29%, which would give us a moderate aortic regurgitation. We can also look at the fastest and the lowest speed in the volume by looking at the blue and the red square, which indicate us on the flow side where the fastest and the slowest pixel are. And that basically ends our evaluation of the study. One nice thing, more for educational reason, is the color over, where you can code on outgoing blood in red and backflowing blood in blue. And you can clearly see that there's systolic normal blood flow in the whole orifice, and in diastole there's the red display, which means a backward flow here in the aorta. This sometimes helps in identifying false and true lumina in aortic regurgitation. Thank you very much.